गाड़ी लेना जो
Dr. Ahmed, we can start, inshallah. Bismillah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah wa salatu wassalam ala Rasulullah. Thanks for the BCMA and for Imam Yahya for inviting me to present on this important topic. It's about diabetes and fasting in Ramadan. So just like to, I would like to introduce myself. My name is Dr. Ahmed Hashim. I am a family physician working in Syria since 2016. I do full service family practice, and I see lots of chronic diseases in my practice, as well as the diabetes. And mashallah, the timing of this topic is very important. So, Brother Anwar, can you hear me? Can you hear me, Brother Anwar?
Yes, I can hear you clearly.
Okay. So, the timing of this topic is very important because, inshallah, Ramadan will be arriving to us, inshallah, with Allah subhanahu wa ta'ala blessing in 2 to 3 weeks. And this kind of period is very important to prepare for fasting, especially when the patient has chronic diseases. So I would like to start with this ayah from Surah Al-Baqarah. And mashallah, this ayah actually summarized the entire topic, subhanallah. So Allah subhanahu wa ta'ala says in Surah Al-Baqarah, أعوذ بالله من الشيطان الرجيم أيام معدودات فمن كان منكم مريضا أو على سفر فعدة من أيام أخر وعلى الذين يطيقونه فدية طعام مسكين فمن تطوع خيرا فهو خير له وأن تصوموا خير لكم إن كنتم تعلمون. So Allah subhanahu wa ta'ala is saying this is a fixed days of fasting, and this part of the ayah وَعَلَى الَّذِينَ يُطِيقُونَهُ. So this is Allah subhanahu wa ta'ala saying people or patients who are able to fast but with hardship, with struggling, they are allowed to break their fast. They are exempt, and they can give like a ransom, feeding a miskin, and if you want to do more, that's allowed as well. So subhanallah, Allah subhanahu wa ta'ala give exemption for sick people and people who are traveling. So let's move to the objective of this talk. So we're going to talk about the pre-Ramadan preparation and planning before the start of the fast. The second aspect will be about the oral medication that we're gonna talk about medications that need to be adjusted or even discontinued before Ramadan. And an important aspect as well is about the insulin type 2 and type 1 management during Ramadan, and the importance as well on the self monitoring of the sugar during Ramadan between all different type of diabetes.
Very loud.
Any questions?
No, doctor, please go ahead.
Sure. And then just I know we have in this kind of workshop a nutritionist that talked about the Ramadan as well, and then we're gonna touch base just one slide on the importance of watching and eating certain things during the holy month. So, mashallah, we are in Canada, more than 1 million Muslim. That constitutes 3.2% of our population in our country. You know, you can see almost 10% of the population lives with diabetes. And inshallah, it's projected that the Muslim population in Canada are going to be double by the end of 2030. So the burden of diabetes will double as well with it, most likely. So, you know, in 10 years, we will have maybe 200 to 250,000 Muslim live with diabetes in this country. And mashallah, majority of Muslims in this country willing to fast, and they have the motivation and the iman. So we're gonna talk about who's gonna fast, who's able to fast, who's not allowed to fast. You know, making this decision sometimes is not straightforward. It needs lots of discussion between the patient, the family physician, or even the endocrinologist, the specialist, as well as the health authorities as well, our imams. So as I said, sometimes you need a few weeks of preparation before the start of the month to talk mainly about risk stratification. This is very important thing that usually done by the physician, the main physician that the patient deals with, most likely the family doctor, and the patient as well, just to assess how ready is the patient to fast, and if there are any things that they need to adjust, anything they need to stop, mainly medication, reviewing the recent blood work, also reviewing the past experiences from the previous fasting, any adverse events that happened. And then this will help both the patient and the physician as well to decide where are they going with fasting or not, and create actually individualized plan. So what I'm going to talk is mainly kind of a general overview, but in the end, this kind of tweaked based on the patient past medical history, the blood work as well. So for risk stratification, basically we will use these kind of factors to classify the patient mainly into three main groups. So the first group is the very high risk group, and they, in my opinion, and based on the Diabetes Association guidelines in Canada that's published in 2018-19, they are not advised to fast. And then the moderate risk or high to moderate risk, they also advise not to fast, but if they decide to fast, they need kind of a close monitoring. And the third category, which is the moderate to low risk, they can fast. So in order to categorize patients on these three categories, the type of diabetes 1 versus 2, the majority of patients is 2, but we have some patient diabetes 2 as well. The current medication, the risk of hypoglycemia, which is the drop in sugar, which is one of the main dangerous complication of diabetes during Ramadan, and actually as well outside Ramadan too. Presence of complication, comorbidities, as you all may know, diabetes can affect kidneys, affect eyes, affect the big blood vessels that you know, supply the heart, the coronary arteries, and also the social aspect and the work circumstances of the patient. And as I mentioned, like the prior Ramadan experience, if any safety issues happened, and how to avoid them if possible. So the four main things actually that we would like to avoid during the fasting actually is the hyperglycemia, where the sugar actually can go more than 16 millimole per liter, both for type 1, type 2, and which may lead in type 1 to a condition called diabetic ketoacidosis. We'll touch base on it later. This is a very dangerous complication of diabetes that, you know, that we need to avoid. hypoglycemia as well, which is the drop of the sugar less than 3.9, dehydration and thrombosis. You know, dehydration was very important, I think, in the previous years, especially 2013, 14. The hours were quite long and the weather was quite hot during summer. I think slowly, alhamdulillah, we are, you know, moving towards the shorter days with Ramadan. This Ramadan will still be long, I think, but I think it will sort of happen in the spring compared to a few years ago when it was the spring. But still, dehydration still can happen. So after the discussion and after the history and physical exam and reviewing a blood test, reviewing any consults from specialists, we usually divide the patient or categorize the patient into 3 main categories. So the very high risk I highlighted in red. So those patients, they must not fast. Mainly, we'll give some examples. So type 1 is more serious than type 2 when it comes to fasting. So you need a very well controlled type 1 if you decide to fast. So if the A1C is the blood test that give us an average of how well controlled is the diabetes over the past 90 days. If it is more than 9, the patient must not fast. History of severe hypoglycemia, which is a drop in the sugar, which happens in the past 3 months. If the hypoglycemia happenings more often, I would suggest maybe once or twice every month or 2. And also if the patient is not aware of the drop in the sugar, this is one of the high risk group. They are not advised to fast. Ketoacidosis, as I mentioned, this is when the sugar goes up very high and the body is depleted from insulin. So there is no insulin to take the sugar to the cells. So the body starts actually to burn fat to get energy. And this is one of the very high risk criteria that patients cannot fast. Any acute illness that happens while the patient is diabetic, like if the diabetic patients got like very sick during Ramadan, let's say they got like influenza or, you know, got say like the COVID-19, if they got infected, they should break their fast. And this is a common sense. Any advanced macrovascular complication like ischemic heart disease, renal failure, patients on dialysis, they're not advised to fast. Pregnant women. So pregnancy on its own, actually, they exempt from, subhanAllah, from fasting. But when it comes with diabetes that's treated with insulin, this will be in my opinion, a big no to fast, and they can substitute later after pregnancy, or they can, you know, give the fidya. The second group, they are the high to moderate risk. So you can see it's still high. The CDA, the Canadian Diabetes Association guideline, they don't put them as just moderate. They say high to moderate. So they still think patients shouldn't fast, but if fasting, they need kind of more close follow-up and more kind of monitoring, mainly on a weekly basis. So again, basically it's type 2 with poor diabetes control, like A1C more than 9, a well-controlled type 2 diabetes on insulin pump, pregnant, again, with gestational diabetes controlled by diet only. So they are lower risk compared to gestational diabetes on insulin, but they're still high risk and still advised not to fast. Chronic kidney disease, stage 3, or stable microvascular complication. Any patient with diabetes that works in high intense labor job, for the risk mainly of low sugar, they need to consult their healthcare provider before fasting. And also type 1, that's well controlled, they need to consult as well to make sure that they know the preparation for fasting, and they know when to check their sugar, and they need also to be aware on how to adjust their insulin dose based on the results. And now this is the low risk. Basically, the patient that can fast most of the times, the patient with well-controlled diabetes that's mainly treated with lifestyle, with metformin, with other stable oral anti-hyperglycemic agents, and even patient on insulin, that's in otherwise healthy individuals. So this part of the topic, we're gonna talk about the oral diabetes medication that are safe. So the first line of the most common one is metformin. So metformin is a drug from a class called biguanides. Basically, they are quite safe because they don't interact with the insulin. They prevent, these drugs prevent a process called the gluconeogenesis that release the sugar from the liver. So they're quite safe. They're usually taken in my practice. I give it twice a day or 3 times a day. So for twice a day, it's easy. So you can take the first tablet after the iftar, second tablet, you can take it after suhoor. If you are on the 3 times a day, so we suggest you take the number 1 and 2. So the first 2 tablets you take it after iftar, and the third one you take it with the suhoor. The other type of medication is the DTP4. Some example, Januvia, Trajenta, Ongliza. These are safe as well. Basically, you just need time adjustment, but there is no dose adjustment, and you don't need to hold any of them during the Ramadan fasting. We have a medication class called SGL2 inhibitors. So these medication actually work on the kidneys. So they need a good kidney function, and they need a good hydration to the body. So these medication, we are saying they are safe, but sometimes you need to lower the dose. Let's say if you are on Jardiance 25, you can go on 10, especially with our geriatric, with our old patient more than 75, when the kidney function is less than 60, when a patient on a diuretics for blood pressure reasons, we usually advise either to reduce, or sometimes we can, if the patient is quite old and the kidney function is low, we suggest temporarily we can stop, and we can substitute with something else during the fasting. And after Ramadan, this medication can be resumed safely. These medications as well, they have another benefit. They are cardioprotective medication. So if a patient with diabetes and they have ischemic heart disease and on let's say Jardiance, we don't advise to hold. So just continue, but they need kind of a closer monitoring. So if a patient like their doctor wants to start one of these medication just for any reason, if the diabetes is not under control or they're just switching, we don't advise to initiate these within 4 weeks of Ramadan, because we need to the body need to get adjusted to them, mainly the kidney function. We advise as well for any reasons of vomiting, diarrhea, low blood pressure. And this is actually applicable in Ramadan and outside Ramadan. These medications need to be stopped. As I mentioned, they work on kidneys and they need a good kidney function. They can do some harm if the kidney is not working properly. We have another class of medication, the GLP-1 agonist. This is one of the newer medications. These are basically they're injectable. So Victoza is an injectable medicine that's subcutaneous daily. Trulicity and Ozempic, subcutaneous once a week. And by the way, like injecting any medication during fasting, or there is not breaking your fast. Doesn't invalidate the fasting. So even like, let's say, just as a maybe off topic, if a patient is offered to get the COVID-19 vaccine during during the Ramadan fasting time. It doesn't break fast. Eye drops doesn't break fast. Nasal spray, there is controversy about it. I mean, just as I mentioned, off topic, insulin injection, they don't break fast. So back to the GLP-1 agonists. These medications also similar to the previous class, the SGL2. They need a good kidney, and we don't advise to initiate prior to Ramadan. If a physician wants to start it, I think it's good to postpone until after Ramadan. And in the same way, in the case of nausea, vomiting, diarrhea, the dose need to be reduced, or even the medication needs to be discontinued. So sulfonylurea, this is kind of the most dangerous class of medication during Ramadan, because these medications, they work on insulin directly. They stimulate the pancreas to excrete more insulin, and the risk of hypoglycemia is quite big when it comes to Ramadan. So if any patients on these medication prior to Ramadan, it's quite advisable to start to switch to a different class of medication. But for any reason, mainly cost coverage, if the patient is not able to afford one of the kind of other classes, mostly for cost reasons and coverage, we usually glycoside is better than glyburide. And even sometimes, because glycoside you can go up to 120 milligram. So if a patient on a higher dose, I think it's good to reduce the dose to 60. In my opinion, more flexible glycemic control is acceptable in Ramadan on expenses of not getting hypoglycemia. So we usually advise patients that we need to see the fasting sugar between 4 to 7. During Ramadan, I think we need to be a little bit more realistic and more flexible and allow a little bit higher, just on the hope that we don't get a drop in the sugar. So this is the sick day management, as we already talked about that. If any of these symptoms happens, vomiting, diarrhea, the patient's about to pass out, they need to break their fast immediately, hold certain medication, diabetes medication, also some other blood pressure medication as well, such as ramipril and the angiotensin receptor blocker inhibitor. They need to be discontinued as well, just to prevent the effect that can happen on the kidney, and seek medical attention immediately. So patients who take insulin, we can talk about type 2. There are different types of insulin. We have the long-acting, the intermediate, and the short-acting. The longer-acting they're the preferred agent during Ramadan as well, because basically they don't elevate the insulin they don't peak, they don't drop the sugar suddenly to cause hypoglycemia. But also it's important to adjust the dose. So if a patient, let's say on 30 units of Lantus, I think they need to adjust it to maybe 20. And with the frequent checking, they can know the appropriate dose. MPH is one of the intermediate acting agents. We don't prefer them during the Ramadan, but as I mentioned, for mostly coverage and cost, if they are not, patients not able to afford the longer acting one, the dose need to be adjusted as well. The short acting ones, they are good. They are preferred options as well. Basically, patients before Ramadan take the schedule is 3 times a day. They take it before, sometimes after meals. So what we do, we advise the patient to omit the one with lunch, because usually there is no lunch. So we have the iftar and suhoor. So basically that's like a breakfast and dinner. So we reduce the dose as well, 20 to 50%, and discontinue the lunch time dose. So this is the kind of the explanation about why we prefer the slow or long acting, the third one, because they know the peak is not high and stays in the system for more than 24 hours. Short acting, they peak with the meals and they go down. So they are good. The intermediate ones is the one that's the mixed. We don't prefer them in Ramadan. And even if for any reason that the patient decided to continue with that, the dose need to be adjusted. So for type 2 diabetes with the insulin recommendation, as I mentioned earlier, the pre-meal fasting sugar need to be 5.5 to 7.5 just to reduce the risk of hypoglycemia. And this is just a temporary adjustment in the normal range. After Ramadan, things should be back to normal, 4 to 7. And patients on complex insulin regimen that they take more than one insulin, different time, I think they need to consult mainly their specialist endocrinologist about whether they're able to fast or not, and if they fast, what's kind of the best regimen for them. So this is the insulin therapy. Sorry, it's a busy slide, but the main idea: patient on a long-acting insulin that basically they take it once a day, just to continue, take it at iftar, reduced to 15 to 30%. Patients that take it twice a day, just continue the same. The first dose they take it after iftar. The second dose need to be reduced 50%, and this is around the suhoor time. As I mentioned, the rapid onset one, they take it usually at iftar and suhoor. You just, omit the lunch time because there is no food in between. Pre-mixed insulin, the intermediate one, we don't recommend them. But as I mentioned, if we decide to go with them, then the dose need to be adjusted. So this is the second half of the slide is very important because basically it talks about what we call in medicine the sliding scale. So patients are the type 2, they need to at least 2 times to check their sugar. I would suggest once before iftar, and maybe second and third time post iftar and post sahur. And patients who are on the basal insulin, the long-acting insulin, based on the number that they get when they check, if they are hypoglycemic by symptoms or when they check they see their sugar less than 4, you need to reduce 4 units. So if the patient is on, let's say, 20 units, their next dose should be 16 units. They need to reduce. And if the number is between 3.95, reduced by 2. The number is between 5 to 7. This is the normal. We don't do any changes. If 7 to 11 means that they're not getting enough insulin, so we have to increase by 2 units. And the same, if the number is quite at 11, we have to go 4 units. So basically, the dose need to be adjusted. And here comes the importance of the regular blood sugar check during Ramadan. And again, I'm sure most of our diabetic patients knows that the skin pricking doesn't break fast, and the same way the injection doesn't break fast. So we need to check pre-iftar, post-iftar, and post-sahur. Type 1 actually is more serious. They need kind of more close attention and close follow-up. Same idea. The Lantus, the long-acting ones, they are more preferred than the MPH, which is the intermediate acting. And once daily acting insulin may be preferred so the once a day is preferred better than the more than once a day. But if it is necessary, we're gonna reduce the second dose by 50% and with the kind of frequent checking. So type 1 diabetic patient, they need to at least 5 times to check. And this is if they decide to fast. The same one, as I said, patients on insulin type 1, they need kind of a weekly assessment and weekly follow-up. And in case of drop in the sugar, they need to cut. They need to break their fast and adjust their dose accordingly. So DKA is one of the stands for diabetic ketoacidosis. So mainly this happens when the people with type 1, it's very rare in type 2, but it still can happen. With type 1, the sugar can go up quite high, no much insulin to bring the sugar inside the cell to burn for energies. The body starts to burn the fat instead, and blood ketone forms. The symptoms of this condition usually is a frequent urination, epigastric pain. Patient feel quite sick. If the patient feel like that, they need to break their fast and check. And if the sugar is quite high, sometimes they, based on how they feel, the vital signs, sometimes they need to go to ER. So monitoring for blood sugar during fasting. So basically, at least as I mentioned, 5 times for type 1 diabetic, more often. For type 2, which is I think at least 3 times, pre-iftar, post-iftar, and post-sahur. For patients that with type 2 and oral medication, I would suggest like frequent check is not as important as the previous 2 categories. But in my opinion, if the patient feels signs of hypoglycemia, which is the drop sugar, this is very important. So hypoglycemia patients, they usually feels sick, they're about to faint, they feel palpitation, fast heart rate, sweating, they feel like abnormal. They usually need to break their fast and they check the sugar too. Hyperglycemia, the symptoms are similar to the DKA, thirsty, frequent urination, they feel dehydrated. Also, they need to break their fast. And additional testing as well on top of the numbers above based on the symptoms. So this is very important aspect as well of this talk, and when to break the fast. Usually breaking the fast based on the numbers and on the symptoms, or sometimes both. If patients feel unwell and check and the sugar is less than 4, they need to break their fast. There is no way. And this is even like outside Ramadan. If it still can happen. If the patient feel hypoglycemic, they just need to drink something sweet or eat something like a chocolate bar just to raise their sugar. Because to be honest with you, hypoglycemia can be more dangerous and can be more life-threatening compared to the diabetes itself. So diabetes is a chronic disease. Its effect actually, last years and months and can be adjusted. But the hypoglycemia, the drop in the sugars actually can be more dangerous. And in the same way, the increase in the sugar, the hypoglycemia is symptomatic. The patient need to break their fast. So the 10 principles for Ramadan nutritional plan. Basically, we need to divide the amount of calories between suhoor and iftar. Just reduce the portion. Maybe the patient can fast, on a date, and then they can go pray and just eat a smaller portion compared to just one big portion that can actually cause postprandial hyperglycemia, which can cause a sharp rise in the sugar, which then basically means they need to take higher insulin dose. So just slowly. Basically, again, a healthy balanced diet is quite advised, like between protein and carb and fat. Avoid sugary, heavy desserts, eating high fiber diet. Hydration is very important between iftar and suhoor, mainly with patients on the SGLT2 inhibitors, as well as patients on the injectable GLP-1, because they need a good kidney, so lots of fluids. Never skip suhoor for diabetic patients. It's a sunnah from the Prophet ﷺ, and actually it's very recommended to take the suhoor, and hydration and low calorie snacks as well with vegetables is advised as well. So just give three quick examples. So we have a sister, 50-year-old, type diabetes, diagnosed a year ago. She's a bit BMI 33, a bit overweight. Blood pressure is acceptable, although could be better. Kidneys good. A1C at 7 at target. Patients take metformin twice a day, atorvastatin for the cholesterol and the blood pressure once a day. So in my opinion, this patient is not a very high risk. The patient, I think, is moderate risk. So with some preparation before Ramadan, I think this patient is, she can fast. She takes metformin twice a day, so she can take the first tablet after iftar and second tablet after suhoor, and she can take her atorvastatin as well at the suhoor time. Perindopril, I think she can take it after iftar or even after suhoor. So again, this patient, I think, is a moderate risk, still able to fast, but still needs to consult with her healthcare provider. We have another example, a female, 28, sister. She's type 1 diabetic, diagnosed at age 25. Her weight is acceptable, blood pressure is acceptable. Her hemoglobin A1C, which is the average sugar for the past 3 months, it's at 9.6. This is actually beyond the target. The target should be at 7. So her diabetes type 1 is not under control, although her kidney function is normal. She is on insulin, 20 international unit. I think this patient is a very high risk to fast. She is type 1. Her sugar is not under control beyond 9, and she is on insulin. If this patient's in the future, like in the next Ramadan, her hemoglobin A1C dropped down, and maybe she can fast. But with this scenario, she's not able to fast because she has higher risk of hyperglycemia and diabetic ketoacidosis. We have a case number 3, a brother, 65-year-old, type 2, diagnosed like at age 50. Blood pressure is borderline, not acceptable for diabetes. So patients with diabetes, their blood pressure target should be around 130/80. This is this is above the target. His sugar is well controlled. He's suffered from chronic kidney disease, goes to dialysis 3 times per week. It's obvious this patient is a very high risk. I don't think he can fast or he will able to fast because of the kidney disease. So just to summarize, the take-home message: high-risk patient must not fast. Moderate to low patient, they can fast with precaution and with regular follow-up. Mainly the type 1 diabetic on insulin, they need close follow-up. Certain medication, as we said, need to be adjusted. The main ones that are dangerous actually is the sulfonylureas, the glyburide, the glycoside. If the patient is able to stop them and substitute, that will be the best thing, because they're very famous. Even outside Ramadan, they're very famous in dropping the sugar. And as I mentioned, dropping sugar is kind of a serious thing. Actually can lead to death. Longer acting, as we said, the preferred option for both type 1 and type 2 to avoid hypoglycemia. If the patient is not able to afford the longer acting, if the intermediate acting, the dose need to be adjusted. Very important, the patient is aware about the risk of low sugar and the symptoms actually, and I will mention them again because they're very important. Patient feels they are going to faint, they feel heart racing, palpitation, sweating, trembling. They need to break their fast, and they need to check their sugar as well. And a frequent sugar monitoring is very, very important. mainly for type 1 diabetes at least 5 times, type 2 diabetes at least 3 times, post iftar, post suhoor, and pre-iftar as well. So the main reference that I use in this presentation is the diabetes guidelines. There's a good guidelines published 2018, 2019. They came with the idea of the risk stratification, and I'm happy to answer any of your questions. Any questions, Brother Anwar?
I think, Dr. Ahmed, there are no questions from the audience. So, Jazakallah khair for a very informative presentation. And
وإياكم إن شاء الله.
we can probably conclude the session. Jazakallah khair.
وإياكم إن شاء الله. جزاكم الله خير. السلام عليكم ورحمة الله.